Hi, my name is Ryan Pulleyblank. I'm one of the IQCE ETN PhD research fellows at the Danish Center for Health Economics, supervised by Professor Kim Rose Olsen, and I'm under the IQCE efficiency team. And so what I'm going to present right now is the results of our first paper entitled Evaluation of an Electronic Health Record System with a Disease Management Program and Healthcare Treatment Costs for Danish patients with type 2 diabetes. So a little bit of background. In late 2010, there was a new national contract agreed between the government and the general practitioners in Denmark. And this contract required that an electronic healthcare record system with a built-in disease management program targeting type 2 diabetes patients would be rolled out within a 3-year window for all general practices in Denmark. And suddenly this was actually discontinued in late 2014, but that's a different issue. The electronic healthcare record system essentially assembled and presented overviews of relevant health information to help GPs in making decisions for the care of their patients with type 2 diabetes. Additionally, this electronic healthcare record system had a built-in system which is providing GPs with feedback regarding their performance relative to their peers at local, regional, and national levels, so they could see how they were performing relative to their peers, and that might target some sort of internal competitive motivation to improve the care of patients. To take a brief look at this system in terms of what the GP might actually be looking at, there are some screenshots from what it looked like. As you see there's a list of all the patients with diabetes who are registered in the system, and lots of indicators, green, red, depending on if things are good or bad, flagging whether additional attention needs to be given to specific patients. You see that in the upper 2 slides here. And then in the lower 2 slides, you see what this sort of GP feedback interface looked like, where GPs could see how they are performing relative to their peers on a number of health-related indicators for type 2 diabetes patients in that care. So the research question and methods. Well, the basic research question is, how did the use of this electronic healthcare record system and the disease management program affect healthcare treatment costs for type 2 diabetes patients? To do this, we identified patients who were attending GPs which used the system at a high level beginning in 2012, and we compared them with patients who attended GPs which never really made use of the system. We have a panel of patient-level data covering the years 2008 through 2014, and these patients were all identified with type 2 diabetes before this period, and also they remained at the same GPs throughout the entire period. So for our treatment group, we have about 16,000 patients, and the definition of a GP which treated at a high level was that they coded 70% of monthly visits beginning in 2012 and continuing through to the end of the system was discontinued. And in our control group, we've got about 18,000 patients at GPs which never coded more than 10% and also never used the disease management program for diabetes. Specifically, what we're looking at is annual healthcare costs, and we're log transforming them so that we are able to estimate percentage changes. But the categories of healthcare costs we consider are total healthcare costs, primary care, medication, non-hospital specialists, as well as hospital, broken down into several subcategories: total, outpatient, inpatient, and emergency. So we use models with patient-level data and GP fixed effects, which, as you can see here, that's pretty much what the model, the fixed effects models are. So this is what we see when we look at the data from 2008 through 2011, all of the 4 pre-treatment years in our case. We see very nice parallel trends across basically all of these definitions of healthcare treatment costs. And then 2012, 13, 14 is our treatment period. We do see some sort of a difference, whether or not this is statistically significant, being a matter of statistics. But we do see some sort of differences following the implementation and at a high level use of this electronic healthcare record system. When we do the statistical analysis, we see indeed at the most important healthcare cost category, which is total healthcare costs, there's no difference statistically. Where we do see some differences are at the general practice level, where we see a small increase, about 3%, highly significant, and that sort of makes sense. That's where this electronic healthcare record system existed and would have made the most obvious difference to healthcare costs. For medication costs, we see nothing. Non-hospital special costs, nothing. Total healthcare cost, total hospital costs, nothing. Outpatient and inpatient costs, also nothing. But where we do see in the hospital category an interesting difference is with regards to emergency health hospital costs. We see a significant minus 6.4% estimate, and that suggests something is going on there. You can see that we've actually got our fixed effect models. We also ran some 2-part models, which gave a binary indicator on the whether or not there was a cost in any given year. And we see that using 2-part models, we don't have any significant differences in terms of our results in the hospital cost categories. So what do we say? Well, overall, there's no significant evidence of an impact on total healthcare costs for type 2 diabetes patients attending GPs who use this electronic healthcare record system at a high level. But we do see this slight positive impact on treatment costs in general practice and the slight negative impact of EHR use on emergency, i.e. unplanned hospital treatment costs. But still no overall significant impact on hospital costs. What this suggests to us is there may have been some improvements in referrals for hospital attendances when appropriate. So instead of getting to the point where a patient needed to be admitted to a hospital for an emergency of some sort, they may have been referred earlier, although this may not have come through in terms of an impact on total hospital costs. We can interpret this as evidence of a procedural improvement in efficiency, quality of care, which is of interest to the Improving Quality of Care ETN. Final summary: electronic healthcare record systems with disease management programs for expensive chronic diseases should not be expected to significantly reduce total healthcare costs in the short run. It's unfortunate that this system was discontinued in late 2014 due to political reasons mainly, but that sort of cuts off the amount of evidence that we're able to evaluate with regards to this electronic healthcare record system. So, thanks. This isn't exactly the way anybody wanted to end this ETN, but it's been a real pleasure, and I really hope get a chance to see you again sometime before too long. Take care.